All right, so care of the patient with cancer. We'll go over the normal characteristics of cells, because when we discuss the different chemotherapies and the biological agents and those type of things, it really determines what part of the cell cycle they work at. So not that you necessarily need to know all these, these little microbiology type things, but just to have a basic understanding of why chemo drugs work the way they do when we know how the normal cell works. So our normal characteristics of cells, they have limited cell division. They undergo apoptosis, which is a programmed cell death, which is why we have cancerous cells. They don't have that normal cell death, and they just keep growing and then become migratory and metastasize. There's specific cell morphology. They have specific differentiated functions. They adhere tightly together. They're non-migratory, again, unlike our cancer cells, and they grow in an orderly and well-regulated manner. All not the characteristics of our cancer cells. So with oncogenesis, the need body cells that retain the ability to divide. So it needs some of those cells that divide so that it multiplies. And genetic mechanism whereby normal cells are transformed into cancer cells. So depending on the part of the cell cycle and what happens is where we get our cancerous cells. And we know that cancer is multifactorial. It can be environmental, lifestyle, genetic, immune function. All those things play a factor in whether or not a patient develops cancer. So here again is the normal cell cycle. So the different chemo medications that patients get determine what part of the cell cycle they work on to stop that cancerous cell growth. Cancer on physical function, we know that cancer can affect everything, every body system, and impair pretty much anything and everything. So immunity and clotting, GI function, peripheral nerve function, motor and sensory deficits, pain, and altered respiratory and cardiac function as well. So the different surgical management, or the different cancer managements that we have then that we're going to discuss, are surgery, radiation, chemo, immunotherapy, photodynamic therapy, and our hormonal therapy. Surgery is our oldest form of cancer treatment. We can use it both prophylactically. Prime example of that is women who choose to have bilateral mastectomies when they have a high risk of breast cancer in the family. That would be a form of prophylactic surgery for cancer treatment. Diagnosis, we use after a mass has been removed, we send it to pathology to determine the diagnosis, of course, and then for cure, control, palliation, if maybe just the surgery needs to be done to alleviate pain, but isn't necessarily going to be curative, assessing therapy effectiveness, and then reconstruction. So radiation therapy, the purpose is to destroy the cancer cells and try to minimally affect those surrounding healthy cells. It can be both local, external, and internal. Ionizing radiation, and exposure is the amount of radiation delivered, and the radiation dose is the amount of radiation absorbed. So with internal radiation, it's implanted into the affected tissue or body cavity, or ingested as a solution and injected into the bloodstream. Something that we need to be mindful of is if we are taking care of patients that are receiving internal radiation therapy, their body fluids can be radioactive. So we do have to dispose of them properly, special type of bags and stuff like that. And you need to be mindful of it because you can become exposed if you're handling their body fluids without proper gloves and those type of things. When patients are undergoing internal radiation therapy, you as a healthcare provider, they do sometimes have you wear like those dosimetry devices, so that way you're not having your levels of radiation exceed an appropriate threshold. So some things that you just have to take into consideration if you're caring for some of these patients that are receiving internal radiation. External radiation, however, poses much less risk to healthcare providers. And the radiation oncologist marks the site, and usually it's done, with a permanent type skin marker, because it can be a couple to several weeks that they might be receiving treatment. So that mark needs to stay in place. So they need to make sure they're not, don't scrub it off or wash it off like in the shower or anything. And I already mentioned that they don't pose as much of a risk to other people because it's local, it's a specific area, and externally being given. So their body fluids and stuff, their excreted fluids don't pose as big of a risk to us. Side effects of radiation therapy: acute and long-term specific site changes, especially with the external radiation. It's going to vary according to site: hair loss, altered taste sensation, fatigue, bone marrow suppression, all are potential side effects of radiation therapy. So you want to provide accurate information depending on if it's internal versus external, those different things that they need to take into consideration. They shouldn't be removing any of those temporary skin markings. Avoiding skin irritation, making sure they're doing adequate skin care, nutritional support, care for that xerostomia, which is dry mouth that they tend to get with radiation therapy. And then risk for fractures, especially if they are having any type of bone radiation, those areas will be high risk for developing fractures. And then exercise and sleep interventions for fatigue, because it is tiring as well. And then our chemotherapy. So we're going to talk about, there's going to be a lot of drugs out there, especially in your reading. I mean, there's a huge table with all the different chemotherapy drugs and biologics and everything. You guys do not need to memorize all the different all the different specific drugs. Unless I specifically mention something by name, then you probably want to know that one. But otherwise, don't worry about all the different types of chemo drugs and get yourself overwhelmed with it, because it can be very overwhelming. So we're going to talk about the different classes. So more so know the classes, but then, like I mentioned, hone in on the ones that I specifically talk about. So our chemotherapy is a treatment with a chemical agent, as we know, and it's used to cure and increase survival time. It can be used alone, or it can be used with surgery and radiation, or it might be done prior to surgery or radiation, just depending on the patient and the cancer involved, of course. And then the cytotoxic effects exerted on the healthy cells and the cancer cells. So that's one downfall with our chemotherapy, is that it does have effect on our healthy cells as well. So here's our different classifications. So depending on what type of chemotherapy drug they're on, depends on what part of the cell cycle it affects. So again, they might be using a combination of different ones. It's going to obviously depend on the type of cancer and what that particular cancer cell does in the cell cycle to determine which type of chemotherapy agent they'll be on. So our alkylating agents inhibit cell division by making the DNA strands bind tightly together. The antimetabolites mimic normal metabolites that cancer cells bind to, and then impairs those cellular regulation and division. The antimitotic agents, or mitosis inhibitors, impair mitosis during cell division. Your anti-tumor antibodies interrupt DNA or RNA synthesis, and then your topoisomerase inhibitors disrupt the enzymes essential for DNA synthesis and cell division. There's other miscellaneous chemotherapy agents as well, but these are kind of our main class of chemo agents. A common alkylating agent that's used is ifosfamide, which is, the other name is IFEX, but ifosfamide is often used, and a side effect that it tends to have is hemorrhagic cystitis. So it's very common for that. So they often will be on another medication to prohibit that hemorrhagic cystitis, which is called Mesna. So those two will often be used in combination. The Mesna is not a chemotherapy drug, but it's a drug that's used in conjunction with the ifosfamide to prevent the hemorrhagic cystitis by it binds to the acrolein and stuff in the bladder. So it helps keep that from happening. So it's important that they oftentimes take those two together. And then here's that big old list. I think this is, this is still the list that's in your book, if I remember correctly, in the latest edition. But yeah, so there's just all sorts of different kinds, and don't memorize all of them. So some treatment issues with chemotherapy: dosage, scheduling, and administration. Dosage, of course, the dosage depends on how high or high low that they can tolerate it. Also depends on tumor lysis syndrome that we don't want to throw patients into, which we'll talk about here in just a little bit with our oncological emergencies. And then the scheduling, it's important that they take the medication routinely at about the same time, just to really promote the most effective dosage of the medication. And then if they're receiving it IV, that is a big consideration that we need to take, is the extravasation in how vesicant it is, all the chemotherapy drugs. If it does become infiltrated or something, it can severely damage the tissues. So that's why most of the time patients that are receiving IV chemotherapy usually have a port placed or a PICC line or something, so that way they can receive the chemotherapy medications in something that's not going to cause them to go in, have something like this happen, because they can lose limbs and such if it does get bad enough. So we don't want that to happen. So specific protocols for handling chemotherapy drugs or their excreta, their body fluids. So also we need to make sure that we're taking those things into consideration, that you do have to be trained in administering IV chemotherapy. You have to have like a kind of like a specific training and certification to administer chemo. And there is specific PPE that you need to wear when you are administering chemo, and also need to be taken into consideration as too when you're disposing of certain bodily fluids as well. So even if sometimes patients get admitted for other reasons, as we know, other than just to receive their chemotherapy. So like what we do oftentimes is, if a patient needs their chemotherapy dose, the oncology nurses will come up and administer it, because they do have it's a very specific of how you have to administer that chemo, and how you have to take care of the IV tubing and everything afterwards as well. And even when we can, of course, administer the oral, there's not much consideration there, other than generally, if you don't have chemo drugs, you should double glove when you're handling those oral chemotherapy agents. And then it'll usually have like something on there that says, cytotoxic agent, handle with precautions, do not handle if pregnant, those type of things. So the oral stuff is different, but the IV specifically, you do need to be specially trained in administering it. So our side effects of our chemotherapy, many of which you should probably already know, neutropenia being a big thing. Our white blood cell count for our patients significantly decreases oftentimes. And if it gets to be too low, we know that their risk of fighting off infection is, they just can't do it. So they might have to be placed in those neutropenic precautions. So the neutropenic precautions, if they get less than 2,000, white blood cell count less than 2, then we should be notifying the physician, and then they might potentially need to be placed on those neutropenic precautions. If and that's more to protect the patient. Those are not, when typically we think of our standard precautions or any patient that's on isolation for whatever reason, it's usually to protect us, but for this is to protect the patient from us. So making sure you're wearing, well, we're already wearing masks for everybody, but masks and good hand washing. They should have private rooms. They should not have any live plants and flowers to decrease that risk of bacteria from entering the room or being around the patient. And then low bacteria diet. So there is a specific neutropenic diet that sometimes these patients have to be on, which mainly just, nothing should be raw. So fruits, veggies, meat, nothing should be raw for them because of the risk of bacteria. So your absolute neutrophil count, your ANC, is a better predictor of their ability to continue chemotherapy, and it's just more adequate assessment of their infection risk than just your white blood cell count alone. So it takes the neutrophils and the bands and everything into consideration to give you a number, which normal is greater than 2,500. But if they start to drop below 500, then they know that it's unsafe to continue their chemo at that time. So they might have to take a break in it and allow their numbers to come back up before they can continue their chemotherapy treatment. But typically, Just our general patients, we look more so at just our white blood cell count, but specifically our cancer patients should be looking at the ANC to determine their risk of infection. Different side effects of chemotherapy. So nausea and vomiting, we know that nausea and vomiting is a big one. So making sure that you are giving them their antiemetics before eating or before their chemotherapy treatments, just to try and prevent any of that nausea and vomiting, to really hopefully improve their nutrition so they don't lose too much weight and have just poor nutrition in general. And then also anorexia goes along with that too. They just don't have an appetite. So not only do they need stuff to prevent the nausea and vomiting, but they also often need appetite stimulant to get them to want to eat. And then the mucositis and stomatitis, esophagitis, those are all potential side effects as well, where they just get those ulcerations in their mouth, throat, and esophagus. Which then of course inhibits them from wanting to eat also. So making sure they're getting good oral care and you're watching those sores and stuff, that they're not becoming infected. They should only rinse though with saline or water, and should not use any alcohol-based products, because that can really irritate those already opened and inflamed areas. So then we also have our thrombocytopenia. So it's a result of our bone marrow suppression. Our normal platelet count is 150 to 410,000. That should say 410, not 4,100. There's an extra zero in there. So 150 to 410 is our normal platelets. And they are said to be critical if they fall below 50,000. They're at a really, really high risk of bleeding, and less than 20,000, it's life-threatening. That's especially that low. Even less than 50 can really cause a lot of problems just with spontaneous hemorrhaging. Shoot, computer's about ready to die. The battery just doesn't last the way it used to. So if it's less than 50, they're at risk for bleeding. Less than 20, it can be life-threatening. Especially if it gets to be that low, they can even have like a spontaneous brain bleed, and it can be very bad. And they have impaired clotting as well. Usually, even if they start to fall less than like 90 to 100,000, they might postpone procedures because of the risk of bleeding, and they might need to have some platelet administration prior to certain procedures. And you just really have to be careful, like if they have a central line placed with their levels being low, just monitoring all those sites for bleeding. Fatigue, alopecia, neuropathy, respiratory depression, and cardiovascular compromise. So respiratory and cardiovascular compromise are big things as well with chemotherapy that we need to be monitoring closely for, because of course those can be life-threatening. Pretty much, any of the chemotherapy drugs can cause respiratory and cardiovascular compromise. So if they start to develop any of those symptoms of respiratory distress or chest pain or anything related to the respiratory and cardiac status, we need to be reporting it to the doctor right away. So then you have your immunotherapy biologic response modifiers, and then other targeted therapies. So we have our interleukins and interferons. These modify the patient's biological response to the tumor cells, and they can have a direct anti-tumor activity. They can interfere with cancer cell differentiation, transformation, and metastasis, and improve immune function. There's some of our common BRMs. So Epigen, if you didn't know that, that is one that is a biological response modifier. So our Epigen is one of those actually. And then our monoclonal antibodies bind to the target antigens. It's often specific cell surface membrane proteins, and they prevent the protein from functioning and prevent cell division. You can see they all end in MAB. So pretty much if you see any drug that ends in MAB, it's going to be your monoclonal antibody. So rituximab is a common one, or Rituxan is the brand name for it. But so these ones all help prevent that cell division. Then your small molecule inhibitor targeted therapy. These are biologic agents that use the molecular features present in some cancer cells as targets and have less impact on normal cells. So that's a benefit with these is that they do have less impact on those normal cells. They block the growth and spread of cancer by interfering with those specific cellular growth pathways and the cellular regulation and growth and progression of cancer cells. So there's a lot of different ones, and you can see they all end in inhibitor. With these small molecular inhibitors, they all tend to have a higher cardiovascular effect. So hypertension is often a side effect, so monitoring that closely. Your TKIs in particular, your tyrosine kinase inhibitors, tend to cause hypokalemia. So monitoring their potassium levels real closely if they're on any of those TKIs. Then we have our photodynamic therapy. Photodynamic therapy is selective destruction of the cancer cells via chemical reaction triggered by different types of light. So the benefits of this, it destroys some cancer cells, it can reduce the size of tumors and can shrink tumors in the airway and esophagus. So if it's a type of cancer that this will work for, it's super beneficial because it targets and it's can destroy those, shrink them. Then hormone manipulation. So you'll recognize a lot of they're hormones, either agonists, antagonists, or inhibitors. So it depends on what the type of cancer is, whether it's something that is sensitive to those hormones or can be destroyed by some of those hormones. So just really, depending on the type of cancer, it helps change that hormonal response depending on what type they are on. One thing that we need to take into consideration with our hormone therapy is our side effects, which are VTE. We know that is a big side effect of your hormone therapy. So making sure you're assessing for signs and symptoms of blood clots, or DVTs and stuff. But then also other side effects, either masculinizing effects in women or feminizing effects in men, fluid retention, acne, hypercalcemia, which can result in an oncological emergency, liver dysfunction, and then our VTE. So our different oncological emergencies, we have our sepsis, DIC, SIADH, spinal cord compression, hypercalcemia, SVC syndrome, and tumor lysis syndrome. So we'll talk about these. So sepsis, the result of neutropenia. This is one of the, sepsis is I don't know how I want to say, common-ish emergency that can occur with patients. And if they do go into sepsis, they do have a 40% mortality rate of cancer patients that develop sepsis. And one big factor with that is that they don't, because their immune system is so suppressed, it doesn't respond in the normal way that people do, because their white blood count is so low or non-existent. It just doesn't trigger some of those responses that most people have. So sometimes by the time it's recognized, it's advanced. And with that, they often tend to also have that like cold sepsis where they have low grade temps, because again, they don't have as much of a normal response that people do with fevers and such. So with this, again, it's the result of neutropenia. The patient's normal flora can enter the bloodstream. Low-grade fever, I should say grade, not grace, sometimes is the only symptom, but also still that cold sepsis. And then DIC is often a result of that gram-negative sepsis, which we talked about DIC when we talked about sepsis already, that just kind of like the bleeding and clotting all at the same time. And then of course, the best management is prevention. SIADH, so some of our cancers can cause SIADH, or syndrome of inappropriate antidiuretic hormone that we just talked about with our neuro stuff. And because some cancers stimulate the posterior pituitary to secrete the antidiuretic hormone. But certain cancers, even if it's not like a brain cancer or a brain tumor or something, they can cause like a ectopic production of that antidiuretic hormone. So not because it's stimulating the posterior pituitary, but the cancer cells themselves make like an ectopic ADH. So small cell lung cancer is one of those that patients can go into SIADH. And just, remember those are fluid retention. They become severely hyponatremic. And certain cancer therapies also can cause SAADH. And I honestly don't know how exactly. I don't understand the pathophys of how morphine in cancer patients can cause SAADH. I started to look it up at one point and then I didn't understand it. It's just confusing to me. So if you choose to, but it won't be a test question. I'll just tell you that right there. So SIADH, which we should already know, then that can be anywhere from mild to severe, depending on the level of sodium of hyponatremia. Can be anywhere from muscle cramps, loss of appetite and fatigue, all the way to seizures, coma, and death. But we're monitoring for the fluid retention, weight gain, personality changes. They can have extreme muscle weakness. And then to treat fluid restriction, increasing sodium intake. So they might need that hypertonic saline. And might have to modify their drug and cancer therapy. And then spinal cord compression, pretty self-explanatory. It's when a tumor or something enters the spinal cord and compresses it. Symptoms, of course, too, are going to depend on the location of the spinal cord involvement. Obviously, the higher up it is, it could be more, you could start to have more respiratory depression, lower, could cause different things, but back pain, weakness, loss of sensation, urinary retention, constipation. And the main treatment, high dose of corticosteroids that then get tapered, high dose radiation to try and hopefully shrink the tumor, or surgical removal, or palliative, maybe just enough to remove, like debulk the tumor to remove some of that pressure on the spinal cord, but may not be able to do it completely to where it's curative. They just might have to do it as a palliative option. Then hypercalcemia. So our normal calcium, 8.5 to 10, which actually I think in the latest up-to-date ATI one, it's 9 to 10, but regardless over 10, because we're talking about hypercalcemia. So cancers that secrete the parathyroid hormone that causing bone to release the calcium into the bloodstream. So bone metastasis can stimulate bone breakdown and bone reabsorption, then releases more calcium from the bone into the bloodstream. And tumors also that cause systemic secretion of vitamin D analogs increase calcium levels, and hypercalcemia can be worsened by dehydration. It usually develops more slowly in patients, so just making sure if they have any of those type of cancers, either bone cancers or anything that, any type of cancer that increases that secreting that parathyroid hormone, just any of these factors, they need to be monitoring their calcium levels closely, that they're preventing it before it happens. Some symptoms of that elevated calcium, though: fatigue, loss of appetite, nausea, vomiting, constipation, increased urine output, skeletal pain, kidney stones, abdominal discomfort, muscle weakness, loss of deep tendon reflexes, ileus, dehydration, EKG changes. We know calcium can affect our heart, so monitoring those closely. Altered cognition that can range from lethargy all the way to coma. And then treatment, lots of IV fluids, avoiding diuretics, because one, we don't want to dehydrate them as well and worsen things. So you got to be careful with those diuretics. And then the biphosphonates. So biphosphonate pamidronate is a common medication that's used to for some of these certain cancers that affect the rise in calcium levels, to prevent it from occurring. So it counteracts the bones from excreting the calcium. So it prevents that bone calcium loss. It's the biphosphonates. Calcitonin, oral glucocorticoids, and then in severe cases, they might need dialysis. All right, then the superior vena cava syndrome is the compression or obstruction of the SVC by tumor growth or clots. It is more common in lymphomas, thymomas, right-sided lung cancer, and breast cancer. So symptoms, more mild symptoms that you'll start to see is edema of the face, especially around the eye. So they start to develop that periorbital edema is one of the first signs. And then as it progresses, engorged blood vessels, erythema of the upper body, edema in the upper extremities, dyspnea, and stridor, and then severe hemorrhage, cyanosis, mental status changes, decreased cardiac output, and hypotension. So of course, especially if it's like a tumor or something that's blocking off the superior vena cava, that of course is going to cause decreased perfusion and hypotension and all those problems associated with it. So treatment, fibrinolytics for clots, if it's clot related, high dose radiation, chemotherapy, and stents. So to open up the SVC to allow for the perfusion to start again. If it's tumors, they might need to radiate and to shrink the tumors, and then chemotherapy as well. So here's just an example of something that you might see in SVC syndrome where the tumors are developing around the SVC, causing the SVC syndrome. And then that kind of is just a picture of what it can manifest as well. And then lastly, our tumor lysis syndrome. Our tumor lysis syndrome, I mean, it's an emergency, but sometimes it can occur as a result of a good thing, of the tumor or the cancerous cells being destroyed rapidly. So you know the treatment's working well, but it's working faster than what the body can excrete those intracellular components. So when there's a large number of tumor cells that are destroyed rapidly, that content, the cellular content, so the potassium and purines are released into the bloodstream, and then the body can't get rid of it fast enough. So then in turn, it can cause hyperkalemia, hyperphosphatemia, and that hyperuricemia, so high levels of uric acid, which we know that, especially with hyperkalemia, we know that that can be very life-threatening. But any of them can have the life-threatening effects on both the heart, kidneys, and the central nervous system. So we still wanted to prevent that from happening. It's also seen in rapidly growing cancers, as well as response to treatment. So depending on what the problem is, they might need to back off on the treatment if it's responding too quickly, which you think it's a good thing, but we don't want this tumor lysis syndrome to occur. Some other cancers that often cause this as well are leukemia, lymphomas, small cell lung cancer, germ cell tumors, inflammatory breast cancer, melanoma, and multiple myeloma. And then the different types of certain chemo drugs tend to act quicker and cause the tumor lysis syndrome as well. Symptoms: lethargy, nausea, vomiting, anorexia, flank pain, muscle weakness, cramps, seizures, edema, altered mental status. And then treatment and or prevention. So hydration, antiemetics, those purine excretion drugs. So if they're on any of those chemotherapy drugs that potentially have a higher risk of tumor lysis syndrome, they might be on these medications to prevent it from occurring, to help the body excrete those contents. So your allopurinol or your sodium polystyrene, that K-oxalate, potentially osmotic diuretics that are used more cautiously because, again, we don't want to dehydrate them. And then dialysis in extreme cases as well. And then just kind of like a little diagram that shows the process of tumor lysis syndrome. And that's it. Okay. So now I want to go over ABGs. Do you guys have any questions about the cancer stuff first before we move right along? All right. So one thing with ABGs, I know you guys did some ABG interpretation like in MedSurg 2, but now we're taking it a step further. So we're not only do you have to determine whether it's respiratory or metabolic, acidosis, alkalosis, now you have to determine whether it's compensated or not. So I'm sure many of you probably learned the tic-tac-toe method, which is fine. If you guys continue to use that, as long as you're getting the right answer, continue doing so. However, I am going to show you the Rome method as well, because what I find with the Rome method, it's a lot easier to just literally look at an ABG and know what it is, as opposed to plotting out your tic-tac-toe and having to like think where you're putting stuff and like what it is. Literally all you have to do is look at your ABG, because it's already got the high and low arrows on it, and you can figure out what it is just by looking at it without doing any additional steps. Because that's how it is. Like I mean, when you look at your ABGs in your labs, they have high, low, they have the arrow there. Or if you have them as a printout, if you have like a rapid ABG machine wherever you work, you print it out and it's right there in front of you. The arrows are already there. So what the Rome method is, so it's Rome. and it is respiratory opposite metabolic equal. So that's what it stands for. So what it's referring to is the pH arrow versus either your respiratory arrow versus your metabolic arrow. So when you're looking at ABGs, what value is our respiratory system? We have three main values that we look at. We look at our pH, right? Which is 7.35 to, oops, not 8, 7.45. And then what else do we look at?
CO2.
CO2, which that is our respiratory, where did I get that? Our respiratory value. And it's 35 to 45. Those are easy to remember because 7.35 to 45, CO2, 35 to 45. And then our metabolic is our bicarb. Our metabolic system is our bicarb value that we're looking at, which is 21 to 28. So when you're looking at whether your respiratory is opposite, your metabolic is equal, that's what we're referring to. We're referring to, is the CO2 arrow opposite our pH, or is our metabolic arrow, our bicarb arrow, equal to our pH? Okay, so our CO2 is an acid. CO2 is an acid. So the higher it gets, the more acidotic it gets. But our bicarb is a base. It's an alkaline. So the higher it gets, the more alkalotic it gets. Okay, because they're the opposite. CO2 is an acid, bicarb is a base. Okay, our pH, the lower it gets, the more acidotic it is, right? And then the higher it gets, the more alkalotic it gets. So when you're looking at your arrows, that's why the arrows coincide that way. So the higher your pH gets, the more alkalosis. The higher your bicarb gets, the more alkalosis. So you're really matching up the problem with what value coincides with it. So on the low end, pH is an acid. On the high end, I'm going to do A and B. I know alkalosis and acidosis both start with A, but alkalosis is a base. So that's where I'm getting the B from. So then your, oops, that's not what I wanted. And your CO2 is an acid, oops, and our bicarb is a base. So sometimes it helps, if you don't want to do the arrows, sometimes it helps people analytically think through it of which one is an acid and which one's a base that matches with the acid or the base problem of the pH, if that makes sense. Okay, let's work. I'm going to work through one, so then you'll get what I'm saying here. Okay, let's say our pH is 7.2. Nope, I said 2. And our CO3 or CO2, our bicarb or bleh, our CO2 is a, we'll say 65. And our bicarb, not carbohydrates. We will say 40. All right, so we're just going to do it real simple first. Is our pH high or low?
Low.
Yes. Is our CO2 high or low?
High.
Is our bicarb high or low?
High.
All right. So just looking at our arrows, we can do the Rome method. So respiratory opposite, metabolic equal. Is our respiratory arrow opposite our pH arrow? Yes, right there. You know it's respiratory. Then if you want to look to see if because they can be mixed, you can have both problems, but I'm not going to do that to you guys. I'm not going to do mixed ABGs, okay? We're going to keep it simple. So we know right away it's respiratory because our respiratory arrow is opposite our pH arrow. And then if you look at your metabolic, is our metabolic arrow equal to our pH arrow?
No.
No. So you know it's not metabolic. So you have a respiratory problem. We know that right off the bat. Then is what type of respiratory problem is it? What's our pH? Is our pH acidosis or alkalosis?
Acidosis.
Acidosis. All All right, so now the next step. Compensated, uncompensated, or partially compensated. So our renal and our respiratory systems are our two major buffering systems. So that's why we look at our ABGs. When it's a respiratory problem, our renal system should be doing something to counteract whatever the problem is. You got to look at the opposing system to determine if it's trying to compensate. Is our renal system, our metabolic system trying to compensate for our respiratory problem? So we look at our bicarb. Since we know it's a respiratory problem, we already determined that. Now we got to look at our bicarb. Is our bicarb trying to combat the acidosis? Yes.
Yeah.
Yes, it is, because your bicarb is a base. It's an alkaline. It's trying to become more basic by rising to combat the acidosis problem. So yes, but our pH is not normal yet, so it's still not fully compensated. It hasn't done its job to bring our body back to baseline, our pH back to baseline. So it's partially compensated. Lauren, your look of confusion is making me giggle. We'll get it, you'll get it. Okay, so it's partially compensated because it's not fully compensated because our pH isn't normal. So that tells you right there, if you ever have a normal pH, well, one, you could have a completely normal ABG, that's different. But if you have, other than everything being normal, if you have a normal pH, you know that it's compensated. Whatever the problem was, you know it's been compensated because the pH is normal. Okay, so anytime you see a normal pH, automatically put compensated, fully compensated. Okay, but it's not, but it's trying. It's trying. At least the system is starting to work. Okay, so now let's do, let me get rid of my, I guess I could.
So got a question.
Yes.
So if the pH is not normal, it's automatically partial.
No. So we'll do the next one. So the first rule, if it's normal, you know it's fully compensated. Whatever the problem is, you're going to look at the opposing system. If the opposing system is going in the opposite direction, not meaning the arrows, but the opposite direction, as in it's going more acidosis or more alkalosis, determining what the initial problem is. So in this case, it's an acidosis problem. Our opposing system is becoming more alkalotic, whichever word it is, to correct the acidosis problem. Now let's say that, so here's an example. So here we're going to keep our pH and our CO2 the same. We know it's a respiratory acidosis problem. Now let's say that our pH or our bicarb, I'm going to cross that one off because it doesn't let me like delete it altogether. Now let's say that our bicarb is 23. Okay. So now we still have respiratory acidosis, but we know it's not fully compensated because the pH isn't normal. So now it's pretty self-explanatory or pretty easy to guess because we just did partially compensated. Now we're doing uncompensated because now if you're looking at it, your bicarb, you got to look at your opposing system. Since it's a respiratory problem, we're looking at our bicarb. Is our bicarb doing anything to correct the problem? No, it's still normal. It's not doing anything. It's just like, that sucks. Sorry about you. I'm going to just chill over here in my normal state. So it's uncompensated. So you always have, as soon as you figure out what the problem is, you always look at the opposing system to see if it's doing its job to try and compensate.
Okay, so on the worksheet, is that the arterial blood?
Yeah, yes, there's a worksheet in the module. You have it in front of you. I know I don't have it.
Yeah, so what does the BE and the PO2 stand for?
Base excess and the oxygen. You don't need those. I mean, you get those when you get your ABGs printout, but in order to determine your compensation, you don't need all that. You don't need The base excess, your PO2 is your oxygen level. I mean, that obviously we just want to know what our oxygen level is, but the base excess helps determine kind of like their degree of acidosis more so. So
that's not a part of any of this.
no, you don't need to. I mean, it's just a part of ABGs in general, but we don't look at it to determine this. So
Okay.
On the worksheet, you can ignore that part.
Thank you.
Yep. All right. So, all right, let's do another one. So now if I would have left that, let me see if it'll let me erase that. Now, if I would have left these two the same, our CO2 and our bicarb the same, let's say now we'll make our pH normal. We'll make it be 7.36. All right, so I already said we know that it's fully compensated. But now, I mean, we already know it's respiratory acidosis because we already worked through it. But if it was 7.36, we still put our arrows. So that we know this arrow is high, we know this arrow is high, but this is normal. So we don't have an arrow, right? Because it's just normal. But you do still want to put an arrow because you want to determine which side of normal it's on to determine what the initial problem either started out as, or maybe, you know, obviously in real life, it depends on the continuum of the disease process that you drew ABGs. Maybe you drew them right before they started crashing and they're getting ready to go into respiratory acidosis. But in this situation, we'll just say they recovered. So it's normal. So you know it's fully compensated. So now this is fully compensated instead. Oh, here, I'll just get rid of the on. There we go. Now we know it's compensated, but you still got to know which side of normal. So you're still going to put your arrow next to it, even though it's normal, because you got to figure out what the problem was. You still got to match up your pH to one of your arrows. So it's still going down. So it's still opposite your CO2. So it's still respiratory acidosis, but since the pH is normal, it's now compensated. Does that make sense? Okay, it's normal. So your pH is normal no matter what. So you know it's compensated. So we've got our compensated there. But you still want to put which side of normal. 7.36, is it on the high side of normal or the low side of normal? Low. So that's why I still put my arrow there.
Okay.
Okay. So, and then you do your Rome. So you still look at your respiratory opposite, metabolic equal. Okay, well, my respiratory arrow is opposite my pH arrow. So I know it's respiratory and it's normal, but it's on the acidotic side of normal. So it's still respiratory acidosis, fully compensated.
So if it's under 7.4, it's low, but if it's above 7.4, it's high.
Correct. And I'm not going to do 7.4 exactly. Okay. You might see it, obviously, in real life, but again, I'm not going to do that to you for testing purposes. All right. So let me erase some of this. Let's do another one. Start fresh. Okay. So now let's say, we'll have a pH of all right. So is our pH high or low?
High.
Draw. Okay. CO2, high or low?
High.
Bicarb, high or low?
High. Everything's high.
Yeah. So all the arrows are going in the same direction. So what does that tell you right away? Is it
Metabolic?
It's metabolic. Respiratory opposite. Well, is our respiratory arrow opposite our pH arrow? No. And then metabolic equal. Is our metabolic arrow equal to our pH arrow?
Yes.
Yeah. So we know it's metabolic. And that's one, I mean, real quickly, without even going further, if you see all your arrows going in the same direction, whether they're all going up or they're all going down, you automatically know it's metabolic, because your metabolic arrow is going to be equal to your respiratory arrow, or pH arrow. All right, so it's metabolic. And then is it alkalosis or acidosis?
Alkalosis.
Yes. Wait, what?
No, alkalosis.
Yeah, alkalosis.
Sorry.
All right, metabolic alkalosis. And then, so now we know it's metabolic. So we got to look at our respiratory problem, our respiratory system. Is our CO2 counteracting the alkalosis? Is it trying to correct it?
Yes.
It is, because it's an acid. CO2 is an acid. So it's getting higher, it's getting more acidotic to correct the alkalosis problem.
Okay, that makes sense.
Yeah. So it is partially compensated because it's trying to correct it. The body, the respiratory system is trying to correct the metabolic problem. Okay.
Is there a way to use this and still do our old tic-tac-toe method?
I mean, yeah.
Okay.
You can still, I mean, you could still, so you can still plot out your tic-tac-toe method, and then you still, I mean, you're either way, you're still going to have to look at your opposing system to
Right.
determine if it's trying to correct the problem.
Okay.
So,
Throwing me off.
huh?
I think that's what's throwing me off.
Okay. I talked to Sheena like 2 years ago. She said she was going to start teaching the Rome method again, because she used to teach the Rome method. Then she went to tic-tac-toe because that's what the instructor used to do that taught this class before me. And then she said she was going to go back to the Rome method. And what I'm hearing is she still hasn't. I don't want to be like one of those that bug her. It's just once it clicks, I mean, it's really all you do is look at the arrows. And that's the thing that's nice about it, because you don't have to put the arrows there. They're already there when you look at a lab value, you know? And so it's like, once you just see, like, it's okay, metabolic. I mean, like I said, the metabolic is the easiest, because if you see all the arrows going in the same direction, you know automatically it's a metabolic problem. And then all you got to do is look and see what your pH is to determine acidosis or alkalosis. And then you just got to look at your opposing system. So no matter what the problem is, you always have to look at your opposing system to see if it's trying to correct the problem. If it's trying to correct the problem, it's partially compensated. So a few tips. pH is normal, automatically fully compensated. If either your CO2 or your bicarb is normal, then it's going to be uncompensated.
Can you repeat that?
If your bicarb or your CO2 is normal, it's going to be uncompensated. Because if one of those is normal and it's the other problem, you know, whatever the other problem is, respiratory or whatever. I mean, if your bicarb is normal and it's a respiratory problem, then it's uncompensated. Your renal buffering system is not doing its job. If it's a metabolic problem and your CO2 is normal, then it's uncompensated because your respiratory status isn't trying to help the metabolic problem. So, I mean, those are just some real simple, even without having to do any critical thinking, like you literally just can know that it's fully compensated or uncompensated, depending if your pH is normal or if one of your other values is normal.
So if all the arrows were pointing down, would that still be metabolic?
Yep.
Okay.
Except it would be metabolic acidosis.
Right.
So we'll say, so let's say our, let's now say our CO2 is 40. What would, so now what do we have?
It's uncompensated, but it's still metabolic alkalosis.
Yes. So now it's uncompensated metabolic alkalosis because our CO2 is normal. It's not doing anything to correct the problem. Right. You guys want to do one more? We got a few minutes. So the worksheet is in your, there's a worksheet in the modules. I think I have a second worksheet too that I'll put in there that I think I forgot to put in. Or we might have time to do it next week during class, depending. We'll see. All right. Let's do. Doing that to another one. Oh my goodness, my email is going crazy. Oh, shoot. There. Okay. All right. So what do we have? pH, high or low?
Low. High.
High.
Yeah, high. CO2, high or low?
Low.
Like,
Bicarb, high or low?
Low.
Low.
All right. So what do we have?
respiratory alkalosis.
Alkalosis. Yeah. Respiratory alkalosis. And then is it, what's our compensation?
Partially.
Yes, partially compensated. So it's respiratory opposite, our respiratory arrows opposite our pH. And then, so we know it's a respiratory problem. We look at our bicarb. Is our bicarb becoming more acidotic to correct the alkalosis problem? Which it is, because remember, our bicarb is a base, so it's getting lower to become more acidotic. So it's trying to compensate, partially compensated. Clear as mud?
I feel like it was a lot more simple than I anticipated it to be. I was terrified when you said we were going to go over it today. I was like, oh my gosh, I'm not ready for that.
It is. I mean, once it clicks, it clicks. I mean, it does. It is. It's one of those things. It takes a hot second to like wrap your mind around, but then once it clicks, it is. You can do it. You guys can do this. So I'm gonna do one more here. Where's my eraser? Oh, I forgot to put that as my pH, in case you didn't know it. And we will make that be, I don't know, we'll just say, okay. Okay, what we got here, high or low? Well, first, what do we know right off the bat before doing anything?
It's fully
It's long,
compensated.
but it's on the high side, so it's fully compensated.
Yes, it's fully compensated, but on the high side, the high end of fully compensated. And then our CO2, high or low?
Low.
Low.
Our bicarb, high or low?
Low.
Low.
Right. All right. So you already said it. It's fully compensated, but what is it fully compensated?
Respiratory. Alkalosis.
Yes. There. So fully compensated respiratory alkalosis. You got it. You guys got this. All right. So there's the worksheets in there. Like I said, don't stop. Don't worry about the ones that are mixed, because I know there are a couple on there that are mixed. So if you come across one of those, just ignore